Mr. Chairman, my name is Patrick Filkins. I'm a pharmacist by trade with additional training in emergency medicine, and I actually trained under Dr. Steck in toxicology, and I have stayed on with Grady and the Georgia Poison Center. And I've testified to this committee a couple times before, so I'll keep my comments on the brief side. The main thing I wanted to speak about today is what we're actually seeing in Georgia. There are a lot of studies that have been published concerning national data, but here at the Georgia Poison Center, we serve the entire state of Georgia, every single county. We're the only poison center in the state, and so we are inevitably the ones being called by providers and by patients who need help after being exposed to these medications, or as Dr. Steck alluded to, unfortunately go into withdrawal from cessation of kratom. But prior to that, Dr. Steck did a good job of alluding to the fact that all of these products are essentially unregulated. They are, could all be marketed as kratom. But a study was just published in where they kind of did a secret shopper and went around to different stores and purchased a bunch of different products and tested all the products as to what they actually contained. And despite being marketed as kratom, up to 80% of them were actually just purified 7-hydroxymetragine products. And some of which, despite saying it contained 50 milligrams or 100 milligrams, could contain up to 700 milligrams of the substance, which would be at least incredibly toxic to our pediatric population. Additionally, the FDA has determined that kratom is not appropriate for use as a dietary supplement under Section 402 of the Federal Food, Drug, and Cosmetic Act. And they concluded that kratom products are adulterated because they lack adequate safety information and function as unsafe food additives. But again, in this same study where they went around and purchased these products and tested them, they also found that up to 60% of vendors marketing these products purported these products to treat pain, or falsely claim that these products are safe in pregnancy, which are certainly not. So the regulatory status, even nationwide, is very murky. But I really want to touch home on what we're seeing in Georgia. So the last time I testified, I had data up through 2025, and alluded to the fact that we have seen a 400% increase in pediatric exposures, and the exposures that are getting called to us are growing up exponentially every year. And since 2018, we're now up to 747 total cases, but we have already seen 161 cases year to date this year in 2026. That has already eclipsed last year, 2025, which was the previous highest year of exposures. Year to date, we've already had 2 fatalities related to kratom reported to us. And the cases that we would document as having a major medical effect, so something such as significant respiratory depression, significant altered mental status, extremely low blood pressure, things that require pretty substantial medical intervention. Those cases have tripled this year compared to last, which was, again, our highest year on record of these sorts of exposures. And, we're not even halfway through the year yet. And 86% of these cases that are getting called to us are needing treatment in a healthcare facility. So regardless of the severity of the case, the fact that kratom being this available, it's increasing the healthcare burden in the state of Georgia, which can also particularly strain our rural counties in which healthcare resources tend to be limited already. And I alluded to pediatric exposure. So in 2024, the last year in which we had, or since 2020 or since 2018, in which we had single-digit pediatric exposures of 3, we've already jumped to 13 year to date. So well above the 400% increase. And in the same study in which they did secret shopper purchasing, 91% of the formulations available were candy-like flavors such as cotton candy, blue raspberry, things that would be marketable to children and things that children would go after if found in the home. So, our current law has pretty good regulations that have been enacted to try to decrease the unsafe exposures to the population. But a recent study was published regarding states with these sort of restrictions compared to states with full ban. And states with these consumer protection laws had over 4 times the rate of severe medical outcomes that I alluded to earlier that we're seeing in Georgia. And they also have kratom detection and fatal overdoses 4 times greater than states with full ban. So although full ban is not going to completely eliminate the availability of kratom, but having murky regulations compared to full ban, at least with the data that we have now, potentially would indicate that full ban may be safer from a public health perspective. But I'll conclude my comments now and answer any Georgia specific questions that you have or any toxicology related question.
Okay, we've got a few questions. I just want to say thank you for being here again and testifying. And I'm going as what I can see in order, and number 16 was first. So Representative Kendrick.
All right, thank you, Mr. Chair, and thank you for your testimony. I just want to be clear about the studies and the fatalities that you mentioned. Are you talking about the pure leaf kratom, a combination of both of them? Because I know we've had a lot of conversation about the differences between pure leaf kratom and then derivatives of it. So I want to be very clear.
Of course. So one of the inherent kind of vulnerabilities, if you will, with the data, the coding system that we use to code all of these exposures, it can't keep up with the amount of products that are available on the market. So I can track a specific brand of an acetaminophen tablet. I can track a specific brand, of a blood pressure medication, just because of the regulatory nature and in the manufacturing and lack of standardization. It's coded generically as kratom. And we do have the availability now to see what our poison specialists are searching verbatim. So I can tell you if the name of the product indicates it's 7-hydroxy or pseudoindoxyl, but unfortunately due to the marketing, most products are just saying it's kratom. So it's hard from our standpoint at the Poison Center, from a public health perspective, to really tease out the exact product and whether it 100% was pure 7-hydroxy or if it was pure leaf, because again they could be marketing it as pure leaf, but really we have no idea exactly what that product was.
Okay, thank you. Okay, Chairman Meeks.
Thank you, sir. Thank you, Mr. Chairman. Just to add on to that previous question, so can you tell us from the incidences that you know of whether those fatalities have been from the synthetic, I guess would be 7-OH version, or the natural leaf?
I would have to go back and read the specific charts. It's probably some information I could provide to you,
Okay.
at a later date, but
Sure.
at the end of the year, we have to report all fatalities to NPDS, and it's at that point where we try to obtain, medical examiner reports and potentially hospital records to really dive in and see if it was either related or a definite cause. But again, that's something that happens at the end of the calendar year.
Okay, thank you. Thank you, and we'll follow up so we can get that info. Thank you. Okay, next will be Representative Mathis. Not Mathis, I apologize. Ridley over here. No.
My apologies.
Not a problem. I have two questions.
Yeah, absolutely.
So when you talk about the fatalities, did they have any comorbidities or was it strictly kratom overdose was the cause of death?
Yeah, again, I would have to go into the chart and see what was coded to see if they had any comorbidities underlying, if it was reported to us. So again, I could, provide.
Because I think that's very important because, saying, well, they had kratom in their system and that caused the overdose when they had stage 4 cancer and they were trying to take the pain. It's not necessarily the kratom that killed them. It could have been the cancer. And then my second question, and the first lady started it, she said in her chart, she showed that it went up to 1,500 calls for a year for kratom. And then she said afterwards, the last 2 years, it jumped to 3,000 calls. How many total calls does the Poison Control Center get? And how do those numbers compare to things like alcohol, marijuana, fentanyl, or heroin?
So actually our most, I'll comment on the substances. Our most commonly called substances are analgesics. So, acetaminophen, ibuprofen, things like that. We really don't get called as frequently as you would think regarding marijuana or alcohol or even opioids. Unfortunately, we don't particularly get called on a lot. And I think a big part of that is because emergency medicine providers, obviously at this juncture in the opioid epidemic, are very well versed in managing those patients. They know to administer naloxone, so they typically don't need, elevated expert help from toxicologists at this point to manage those cases. So I couldn't give you an exact figure on how often we're getting called, but I will say I'm willing to wager it's a lot less than you would think. And I'm sorry, the first part.
The total number of calls y'all get
Yes.
per year.
So the total number of cases that we manage varies year to year. Last year we managed about 75,000 cases. We're typically either the third or fourth busiest poison center in the country.
Okay, so out of the 75,000, 3,000 or so were for kratom.
So that was, I believe Dr. Steck provided data nationally. So that
Also, it was 3,000 nationally.
correct.
I mean, like, do you know what the poison?
Our year to date is 161 cases.
So 161 out of 75,000.
Well, to date, it would be.
Okay, 35 or
Yeah,
half that
yeah.
number. Yeah.
Sure.
So 161 out of 37.5.
Yeah.
Okay.
Yeah.
Okay. Thank you.
Okay, thank you, and Representative Al.
Thank you so much. I want to go back to that figure that you cited before, that there's been a 400% increase in pediatric exposures.
That was up to 2025.
So 2025, yeah. Obviously, the point of a study committee ultimately is to develop policy recommendations that we can work on as we come back into the next session and sessions beyond. Let's talk just for a second about the marketing and the flavors that you cited as being contributive to pediatric exposures, in particular because of appealing to young children. I think we could probably all agree, regardless of our stance on this, that children should not be taking the substance that is illegal for people under 21 to get in this state. Can you talk a little bit about your perspective on something we've talked about with respect to, for example, vaping, where we restrict the type of marketing and the types of flavors and presentations that can appeal to a younger population, for example, fruit and candy flavors, how it is marketed, to whom these ads are shown. With the vaping, something that we've talked about a little bit more, how it's presented commercially is oftentimes vapes are presented as a safer alternative for cessation. Sounds a little bit familiar in this setting, right? For smoking cessation, but I think it's maybe a little bit more of a dubious claim when you're trying to talk about smoking cessation for an older population, but you're selling cotton candy flavored vapes. Do you think there's a role for that type of flavor restriction or marketing restriction in kratom sales?
Certainly, you know, I think in addition to minimizing the appeal to, and I won't even say, you know, pediatric population. When I say pediatric, that is patients 6 years and under. So obviously, you know, a 6-year-old is not going into the gas station and purchasing these products, right? It's more so if it's laying around in the home, they think it's a gummy worm or what have you. So, you know, in that regard, I think there's no reason to have marketing such as that. You don't have to appeal to the adult population. I think a lot of people who are using this product know what they're using it for, and you know, there's no reason for it to be more accessible or more appealing to children. Additionally, you know, there should certainly be packaging restrictions. I think a big poison prevention initiative historically has been child resistant packaging, and specifically, you know, if they're capsules being in a bottle that, you know, children under the age of 6 can't open, you know, within 15 minutes, something such as that. So I think that's another potential initiative that could be undertaken, is preventing the sheer amount that these children can be exposed to, and you know, that is historically done with all, you know, over-the-counter medications through child resistant packaging.
Okay. Thank you very much. That's it.
All right.
Appreciate you being here. We'll touch base again. Appreciate your involvement and work with Georgia Poison Control.